A very good morning to all of you. Welcome to the CPD webinar series organized by Society for Health Research and Innovation. First, let me introduce you with the housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to you to join in. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. These are to improve and maintain the standards of the CPD programs conducted by Shri, and thank you for your strict adherence and your kind compliance. You can ask questions at the end of the webinar by typing it in the chat box. And also, if you have very specific questions, you can email us on officeshri13@gmail.com. So today's topic is update on management of heart failure in chronic kidney disease. The guest speaker for today is Dr. Nadeesha Nishanthi, consultant nephrologist, Teaching Hospital, Anuradhapura. She was board certified as a consultant nephrologist in 2019. And she is a member of American College of Physicians and also International Society for Nephrology. And she was awarded with the Most Innovative Outstanding Physician in 2022 for expansion of CKD service in Northern and North Central Province. Over to you, Dr. Nadeesha.
Thank you, Karthipal, for that kind introduction. So my topic today is management of heart failure, HFpEF and HFrEF in chronic kidney disease patients. So can you see this graph? So this is very important. How do you define the chronic kidney disease? If the eGFR is less than 60 and or USCR more than 30 milligram per gram for persistent for more than 3 months, we call it as chronic kidney disease. And both eGFR and USCR are independent cardiovascular risk factors. Can you all see these charts? This is the CKD GFR classification according to the KDIGO guidelines, and these lower eGFRs and higher USCRs are more risk factors for chronic kidney disease. So, and the cardiovascular disease. So cardiovascular mortality rates is increased when the eGFR is lower as well as when the UACR is rising. So when you take the pathophysiology, so both are similar, like the risk factors for chronic kidney disease and risk factors for cardiovascular disease, both are similar, right? So I will that elderly age, obesity, hypertension, diabetes mellitus, hyperuricemia, dyslipidemia, and family history are risk factors for chronic kidney disease, as well as specific risk factors like oxidative stress, albuminuria, toxic metabolites, inflammation. Those are both risk factors for chronic kidney disease. So, as well as cardiovascular disease, they are like linking each other. The similar risk factors for chronic kidney disease are risk factors for cardiovascular disease. And when the eGFR is lower and when the UACR is rising, the risk factors for this heart failure is rising in chronic kidney disease patients. So, my case is 46 years old patient, diagnosed patient with chronic kidney disease stage 5. He's a young patient who admitted to our ward. He admitted with exertional dyspnea, NYHA class 3. He had significant orthopnea, paroxysmal nocturnal dyspnea, nausea, vomiting, fatigability. But the problem is his eGFR was around 15. Blood urea level was high, but slightly high, high 16, and 2D echo showed ejection fraction was normal with significant diastolic dysfunction. So am I dealing with a patient with uremia? Is he due to these is symptoms due to uremia and chronic kidney disease with fluid overload, or these symptoms related to the heart failure with preserved ejection fraction, quite vague whether we are dealing with the patient with end-stage renal disease patient or the patient with heart failure with preserved ejection fraction. So would be the next step of management? Am I going to give more IV diuretics, IV diuresis and offloading the patient, initiation of peritoneal dialysis with more icodextrin fluids, initiation of CRRT, or initiation of hemodialysis, especially hemodiafiltration? So at the end of the lecture, I'll tell you what is the next step of management, because we will be confused whether these symptoms due to uremia or symptoms due to heart failure. Okay, so the chronic kidney disease, as I mentioned earlier, the risk factors are similar to cardiovascular disease as well. So what is the pathophysiology? They share common risk factors include diabetes, metabolic syndrome, and systemic inflammation, oxidative stress, elevated neurohormones, mineralocorticoid receptor activation, and venous congestion. So it's very difficult when they are coexist. When the CKD patients are having more than 50% CKD patients are having heart failure with preserved ejection fraction. When we did the 2-day course, their ejection fraction was normal, but they are having heart failure symptoms. So, because they all have systemic inflammation, neurohormonal sympathetic activation, and vascular stiffness, so all these conditions cause heart failure with preserved ejection fraction as well as chronic kidney disease. When there is gradual reduction in the intra-glomerular capillary wall pressure, they cause chronic kidney disease. When their central venous pressure rise and cardiac oxidative stress levels are high, then this causes heart failure with preserved ejection fraction. So more than half of the CKD, as I mentioned, will have heart failure. Chronic kidney disease patients are having heart failure. So how do we diagnose this heart failure with preserved ejection fraction? So ideal thing, clinicians, we all are clinicians. So bedside clinical examination is very, very important. So JVP elevation, the presence of ascites, presence of pleural effusion, and there's a specific clinical sign, dyspnea or decreased saturation during bending. So that is very specific for heart failure. So that we call it as bendopnea, right? Bendopnea. So bendopnea is very, very specific sign of heart failure, because our patients, most of them are fluid overload, most of them JVP is elevated, most of them are having ascites, effusion. But if the patient is telling that patient is having significant shortness of breath while they are bending, bendopnea, that means that's suggestive when there is increased left ventricular end diastolic pressure and increased pulmonary edema, increased primary capillary wedge pressure. They mention they are having dyspnea, shortness of breath while they are bending. So that is an important clinical sign. So there's a scoring system to diagnose HFpEF, heart failure with preserved ejection fraction. That we call it as HFpEF score. One thing is clinical size. When we mention this HFpEF score, that showed H2 means hypertension, obese, and F means atrial fibrillation, and when they are having pulmonary hypertension, E means old age and high increased left ventricular filling pressure. So we can measure the left ventricular filling pressure with cardiac catheterization with cardiac catheterization. So heart failure with preserved ejection fraction is not just diastolic impairment. So diastolic dysfunction, pulmonary hypertension, chronic inflammation, so and specific cardiomyopathies cause this, like uremic cardiomyopathies cause this heart failure with preserved ejection fraction. Even though your echocardiogram is normal, they can have preserved ejection fraction, because that's why patients are symptomatic, but echocardiogram shows ejection fraction more than 60%. So that means they are having significant diastolic dysfunction. If they are not having chronic kidney disease, we can diagnose it with the biomarkers like BNP and NT-proBNP levels. So usually BNP levels more than 80 and NT-proBNP level more than 220. However, in chronic kidney disease patients, their values anyway higher. So we can't go by BNP and NT-proBNP levels in chronic kidney disease patients. So what are the kidney parameters? Strongly predicts heart failure. If the patient is having atrial fibrillation, if the patient had prior heart failure, prior coronary artery disease, EGFR is lower patients, and if the UACR is higher patients, they are strongly predicts more vulnerable to heart failure. That's why I have early mentioned as well. When the patient's EGFR is lower, or if the patient's UACR is higher, if the patient had the atrial fibrillation episode, the patients had a history of ischemic heart disease, coronary artery disease, then they are higher risk for chronic heart failure. So let's take a chest X-ray. For the nephrologist, this chest X-ray might be fluid doublet, just fluid doublet. For the cardiologist, it's heart failure. So how can we differentiate? That's very tricky, right? So when we see the chest X-ray, there is a prominent pulmonary hilar markings and curly B lines, cardiomegaly, curly A lines. So this sort fluid overload. This is a chest X-ray of a patient with fluid overload. So how do you diagnose? Because in chronic kidney disease patients, we can't go by, as mentioned, with NT-BNP or BNP levels. If it's negative, then of course we have excluded heart failure. But if it's positive, we can't say whether it's due to chronic kidney disease or heart failure that BNP levels. So ideal thing is cardiac catheterization. Cardiac catheterization, and it shows increased left ventricular end diastolic pressure that with the preserved systolic functions, that means that patient is having heart failure with preserved ejection fraction. Unfortunately, we can't do for each and every patient's cardiac catheterization. So specifically, then we need to ask from the cardiologist that we are suspecting these patients left ventricular high diastolic dysfunction. Diastolic dysfunction is suspected, and we need to ask from the cardiologist specifically check the 2D echocardiogram for diastolic dysfunction. Because left ventricular end diastolic pressure measurement is the ideal, but cardiac catheterization we can't do in the hospital for each and every patient. And then go by the symptoms and signs. Symptoms and signs of heart failure like ascites, effusion, bendopnea, elevated jugular venous pressure, and also higher left ventricular filling pressure. Echo findings of high left ventricular filling pressure. So, as I mentioned earlier, BNP or pro-BNP levels are excellent negative predictive value to exclude heart failure in chronic kidney disease. If it is negative, we can say that this patient is not having heart failure. So, heart failure with preserved ejection fraction is the dominant form of heart failure, and the HFpEF is very high in chronic kidney disease patients, and the symptoms of chronic kidney disease and symptoms of heart failure in those patients are merged. We have to differentiate whether this patient's symptoms are due to uremia or this patient's symptoms due to heart failure. And higher UACR identifies higher risk, and we have to prioritize the symptoms and signs of heart failure. So that's why cardiologists and nephrologists need to work together with these patients. So how do you treat? The problem is the most heart failure trials, they excluded patients with EGFR less than 30 or dialysis patients. Only a few trials, I will tell, with the subgroup analysis, they included lower EGFR patients. And for all patients with CKD and heart failure with preserved ejection fraction, the use of RAS inhibitors can reduce all-cause mortality as well as hospitalization. So how do you manage heart failure in chronic kidney disease? So exercise. For all the eligible patients, exercise with the observation, exercise is the number one treatment. And SGLT2 inhibitors for all eligible patients. As I mentioned, eligible patients means if the EGFR is over 20, diabetic or non-diabetic, proteinuric or non-proteinuric, SGLT2 inhibitors are the number one treatment. And then if the EGFR is more than 20. And then ARNI is better than ARBs or ACE inhibitors, then mineralocorticoid receptor antagonist, as well as diuretic agents as needed. We should not stop diuretics as the patient's creatinine is rising after initiation of diuretics. I will tell you later about that. So this is the American Heart Association how to manage patients with preserved ejection fraction more than 50%, diuretics, SGL2 inhibitors class 1 recommendation, ARNI, it is better than ARBs as I mentioned, and then MRAs as class 2B recommendation. ARNI means angiotensin receptor nephrolysis inhibitors, and it is available in our country, right? Mineralocorticoid receptor agonist, we can use steroidal as well as non-steroidal. So there are a few trials. I'll let you know what are those, right? So this is the number 1 trial with SGL2 inhibitors. There are 2 trials. So we showed that for the heart failure patients, they reduced these SGL2 inhibitors reduced cardiovascular deaths as well as hospitalization with heart failure. And it's a class 1A recommendation, right? So they included patients with nearly 6,000 patients with ejection fraction more than 60%, that means heart failure with preserved ejection fraction, and lesser number of patients with atrial fibrillation and as well as hypertension and elderly population. That showed significantly empagliflozin reduced hospitalization with heart failure as well as cardiovascular deaths. And then came the DELIVER trial that they used dapagliflozin, and 6,263 patients included. And this also showed a significant reduction in hospitalization with heart failure as well as cardiovascular deaths in dapagliflozin treatment group compared to the placebo. So both trials showed that SGL2 inhibitors, there's a significant reduction in cardiovascular deaths as well as hospitalization with heart failure. So what about the low eGFR level patients? Because they included mainly patients with normal eGFR. So this showed with ejection fraction more than 60%, as well as they included some patients with ejection fraction more than 40%. Both groups showed that there's a significant reduction in cardiovascular deaths, as well as hospitalization with heart failure in SGL2 inhibitors group compared to placebo. So there is a subgroup analysis with lower eGFR that showed that eGFR lower group also showed there is a significant reduction in cardiovascular deaths and hospitalization in SGL2 inhibitors treated group compared to placebo. So always class 1 recommendation that SGL2 inhibitors are better for treatment of heart failure in both lower eGFR as well as normal eGFR group. Then I will let you know about Paragon heart failure trial. That is also very important. They compared ARNI, that is angiotensin receptor nephrolysis inhibitors, to ARBs, and that showed that ARNI, the sacubitril valsartan, had significant reduction in hospitalization with heart failure and cardiovascular deaths compared to just angiotensin receptor blockers. And they included 4,822 patients with symptomatic NYHA class 2 to 4 with ejection fraction more than 45%. So that means they included mainly patients with ejection fraction more than 45% with heart symptoms of heart failure. And this showed significant reduction in heart failure, and the subgroup analysis of lower eGFR levels and normal eGFR levels. This showed that lower eGFR levels, that means eGFR less than 60, they have more beneficial with sacubitril valsartan compared to valsartan. So the sacubitril valsartan group had more beneficial with when the lower eGFR is lower compared to the normal eGFR. So don't be scared to give this ARNI. angiotensin receptor neprilysin inhibitors. We usually use it if the eGFR is more than 25% and when they are having symptoms of heart failure with normal ejection fraction. So then there is a combination of trials, paradigm heart failure and paragon heart failure. They extended many patients with normal ejection fraction, and that showed there's a reduction in cardiovascular deaths, hospitalization, heart failure in this ARNI group compared to the valsartan. And this trial, this TOPCAT trial for mineralocorticoid receptor antagonists. So this showed in the patients with normal ejection fraction, that means ejection fraction more than 45%. That shows that mainly women's compared to men's, they showed both lower ejection fraction as well as normal ejection fraction. This MRA showed beneficial, but however, in men's, only ejection fraction less than 50% patients only they showed more beneficial in MRA. So MRA is used mainly for patients with lower ejection fractions, and it shows beneficial with EGFR lower group. Right, so we can use mineralocorticoid receptor antagonists for EGFR lower group for reduction in cardiovascular deaths as well as hospitalization, heart failure, and aborted cardiac arrest. So this showed that treatment group had more reduction in cardiovascular death, aborted cardiac arrest, and hospitalization of heart failure. So both steroidal and non-steroidal MRAs, but we need more trials of selective non-steroidal MRAs like Finerenone. There is no trials for that, but other mineralocorticoid receptor antagonists showed that there is reduction in hospitalization of cardiovascular deaths, heart failure in this treatment group. So mainly patients with low eGFR, less than 60%, less than 60 eGFR with symptomatic heart failure patients, and this shows women's mainly showed both lower ejection fraction as well as normal ejection fraction, but for males only for lower ejection. So that's why cardiologists also mainly used patients with low ejection fraction group this mineralocorticoid receptor antagonist. So this TOPCAT post-hoc analysis showed this obese, diabetes, chronic inflammatory patients, and renal dysfunction patients, they preferentially response to spironolactone than the placebo. So the renal outcomes that showed there's a subgroup analysis. So spironolactone is effective, consistent across the range of even though in the lower eGFR. So, however, we are not using steroidal MRAs if the eGFR is less than 45 like that, but we can use the non-steroidal MRAs in lower eGFR population. So this is a strong heart failure group. So strong heart failure group, they compared for acute heart failure patients, they compared this intensive treatment group versus the moderate or low intensive treatment group, and that showed intensive treatment group had more beneficial in reduce all-cause mortality. That's why we should not be scared about rapidly rising creatinine, rapidly lowering of the eGFR when we treat with ACE inhibitors, SARBs, ARNI, beta blockers, because they all cause mortality with the time is better with the rapid up titration and offloading patients compared to the other group. So only if this strong heart failure renal outcomes showed that in the initial period there is rapid decline in creatinine, but with the time being they come to the same range. So that's why changes of baseline in eGFR, even though there is initial dips in eGFRs, with the time being it comes to the normal range, same range. So this is Also a STEP HFpEF trial which showed that is they included patients with GLP-1 receptor agonists. In near future, it will be available in our country as well. This showed mainly patients with obese and heart failure, and they recruited patients, 529 patients, and that showed semaglutide showed a reduction in cardiovascular deaths and KCCQ score with semaglutide had a better outcome than the placebo. So this STEP HFpEF trial. So how do you treat? So loop diuretics when the patient is fluid overload. When the patient is fluid overload, when we give the loop diuretics, right, there is rise in serum creatinine. That's we call it as a permissive hypercreatinemia. Some physicians also they scared when they give diuretics when the creatinine is rising, they suddenly stop the diuretics. This should not be happen. When they suddenly stop the diuretics and allow patients to be overloaded. So that's not be. If only if the EGFR drop more than 50%, 40 to 50% only, we should stop the loop diuretics. Otherwise, for the fluid overload with symptoms of heart failure patients, when they will be treated, even though there is rising creatinine, we need to continue the diuretics. And then, as I mentioned earlier, SGL2 inhibitors is a class 1A recommendation. With that two trials showed it, Emperor Preserved and Deliver trial, and then RAS inhibitors, mineralocorticoid antagonists, and sacubitril valsartan. Phosphodiesterase inhibitors, we should not use. It is contraindicated. Nitrates, not used. It is contraindicated in chronic kidney disease patients. We will, there's a recommendation for the prevention of heart failure with type 2 diabetes mellitus and chronic kidney disease, patient SGL2 inhibitors. So remember, SGL2 inhibitors, not only for diabetic as well as non-diabetic, as well as not only for proteinuric and non-proteinuric with EGFR of more than 20%. So these are the summary exercise, very, very important with the SGL2 inhibitors, class 1 recommendation, and titrate with loop diuretics. And as I mentioned, for women with all range of ejection fraction, MRAC is effective. However, for men, it's only more effective with the lower ejection fraction group, ejection fraction less than 55%. We can add mineralocorticoid receptor antagonists. So with the EGFR, if more than 45, we can use steroidal MRAs. And if the EGFR is lower, we can use selective MRAs like finerenone and Fineron. Fineron we can use if the EGFR is more than 25%. Or otherwise spironolactone if the EGFR is more than 45, and patients with lower ejection fraction group has more beneficial than the normal ejection fraction group for mineralocorticoid receptor antagonists. For women, across all the ranges of ejection fractions, mineralocorticoid receptor antagonists are beneficial. And then ANI, my cursor is not working. ANI, so women's with all ejection fraction group and men's with 50 low ejection fraction as well as like ejection fraction 55 to 60%. So that's why RD mainly used in patients with a lower ejection fraction group, but we can use it in the women's for all the ejection fraction group. And it showed RD is more beneficial than the just mineralocorticoid receptor, just ARBs, angiotensin receptor blockers. So ARNI is more effective than just ARBs for patients with lower EGFR level group. Lower EGFR with heart failure with preserved ejection fraction as well as heart failure with reduced ejection fraction. So that is Paragon heart failure trial. This is TopCat trial, and then came as Emperor trial and the Deliver trial, and then If the patients are not eligible for ANI, or like they are not tolerate, and sometimes it is very expensive, then we have to add angiotensin receptor blocker. And then came this step with the GLP-1 receptor agonist, semaglutide, which reduce cardiovascular deaths, and the semaglutide. Actually, why it is very important, because even in very low EGFR levels, like EGFR was 15, less than 20, because only EGFR more than 20, we can use SGL2 inhibitors. And only if the EGFR is more than 25, we can use the ANI. Only if the EGFR is more than 25, we can use MRAs. We can initiate MRAs, like Fineron. And if the EGFR is more than 45, we can initiate MRAs, any kind of MRAs. But this GLP-1 receptor agonist, they showed even at low EGFRs, we can use it, and it showed significant reduction in cardiovascular deaths and hospitalization of heart failure. And the patients, especially the trials done for patients with obese population, and they showed reduction in body weight as well. And so there's another drug called GLP and GIP receptor agonist. It will come in future. That also we need more trials for CKD population. That also showed significant reduction in cardiovascular deaths. So then we come to about the renal replacement therapy. So patients who are end-stage renal disease and they are hypovolemic, very difficult to manage. When they remove the fluid, their creatinine level is rising and they are going into more kidney injury, right? So and more hypotension. So when we remove, they develop lowering of the blood pressure, and they can develop non-STEMI MIs like that. So how do we, for the end-stage renal disease patients, like as I mentioned, our first patient, we came to our first patient, right? His EGFR was 15%. Uremic symptoms also there, with symptoms of heart failure, and his echo showed ejection fraction 60%, but significant diastolic dysfunction. So how do we treat such patients? So ideal thing is we can use of diuresis, like IV diuresis, but he can be uremic, creatinine level can rise, that patient. So then we can use gradual reduction in the ultrafiltration, which was like heart friendly, like less than 1.5 liters per day, like gradual reduction in the heart failure with considering hemodifiltration. So rather than hemodialysis, hemodifiltration is more better for heart failure patients. So hemodifiltration with gradual reduction in the offloading the patient. Dialysis is a one treatment. And then consider peritoneal dialysis. So peritoneal dialysis is ideal for heart failure patients. And selected patients not in our country combined heart and kidney transplantation. So kidney transplantation, we need to combine with heart if they're having heart failure. So when we use CAPDs, we usually use one cycle with icodextrin. That is ideal. So still trials are going whether we can use SGLT2 inhibitors, whether it is efficacy is better, efficacy is okay with the dialysis patients. We need more trials. So once if the EGFR more than 20, always consider SGL2 inhibitors, AC inhibitors. So ANI we can use if the EGFR is like about 20 to 25%, we can use ANI. So dialysis patient, when we come, we need like a multidisciplinary approach. Like we need to assess the volume status prior to dialysis, monitor the symptoms and vital signs during dialysis. If the ultrafiltration goals not met, or if the hypotension occurs during dialysis, when we remove more fluids, then patients develop hypotension. So and patient can deteriorate. So that's why I mentioned, like gradual reduction in the the volume status, like ultrafiltration glow, like 1 to 1.5 liters per day. We need to gradually reduction do the ultrafiltration. So, and then for the patients, we need to advise don't take fluids, avoid sodium, avoid fluids intake, and adhere to medication regime and monitor weight. And as a nephrologist, we need to set up an ultrafiltration goal, and we need to avoid intradialytic hypotension. When we remove the fluids, they can develop intradialytic hypofiltration. That's a gradual reduction in the removing the fluids, and manage comorbidities, and it will change with acute illnesses, as well as. So I mainly focused on heart failure with preserved ejection fraction, SGLT2 inhibitors, ARNI or ARBs. ARNI is better than ARBs or less, and MRAs. MRAs, as I mentioned, if the eGFR is more than 25%, we can use Fineron. If the eGFR is more than 45, we can use any mineralocorticoid receptor antagonist. And please don't stop the drug if the potassium, because lots of patients, when the potassium is slightly high, like more than 5, they stop the drug. We should not use it like that. Only if the potassium is more than 5.5, we consider stopping the drug, but we can combine it with potassium binding regimes, like we don't have patyroma or sodium cercanium silicate in our country, but we have calcium resonia. So we can combine it with that and treat for hyperkalemia, but continue the drug like ARNI or MRAs or S inhibitor. Only if the eGFR drop more than 30%, we usually stop the drug. And for heart failure with reduced ejection fraction, we can use beta blockers, HGL2 inhibitors, ARNI-ARBs, MRAs, ivermectin, and dilators. So, and the exercise is very, very important, as well as DASH diet. What you call is DASH diet. So my next patient, 75-year-old woman with hypertension and type 2 diabetes mellitus, hospitalized 3 times in 4 months for congestive heart failure, and she was on furosemide, metoprolol, losartan, and metformin. And she had presented for primary care physician with shortness of breath, bilateral ankle edema, and serum creatinine was 1.5 with potassium 5.2. USCR was higher, 800 milligrams per gram, with HbA1c of 6.8, with ejection fraction of 36%. So what is the next step of management? Do you add SGL2 inhibitors, omit losartan and add sacubitril valsartan, add ACE inhibitors, A and B? So obviously, as I mentioned earlier, eGFR is okay, 34%. So what do you do? Of course, we need to add SGL2 inhibitors if there is no any contraindication. And what are the contraindications for SGL2 inhibitors? We'll discuss it later. And then, as I mentioned, ARNI is always better than the ARBs. So we can omit losartan and add sacubitril valsartan. So these are the top 10 take-home messages. So new recommendations for heart failure with preserved ejection fraction, SGL2 inhibitors, class 2A and MRAs and ARNI. And we need to treat the patient's hypertension. We need to treat the patient if they had atrial fibrillation, we need to treat them and avoid use of nitrates or phosphodiesterase inhibitors in HFpEF patients, and use of ARBs. If the ARNI is not available, you have to use angiotensin receptor blockers. So I think I have finished my presentation. So we can come for the discussion.
So we have few questions in the chat. So one question is that what are the freely available ARNI in Sri Lanka and dose?
Actually, it's not available in government sector, but that's why I mentioned only if the patient can afford, we can prescribe sacubitril valsartan. I think there are few brands available. We can mention sacubitril valsartan if the EGFR is more than 20. And only if the EGFR is initiated, if the EGFR didn't drop more than 30%, we can continue the drug. I mean, from the lab to lab, this EGFR values differs. So, if even though lab mentioned EGFR 20, that EGFR level can be like 18 to 22, that range. So we can't say it's that patient ideally is in 20, but it can be 18 to 22 range. So that's why I usually initiate the drug if the EGFR is more than 25, but you can start it. That is better than the ARBs for heart failure with CKD patients.
Then the next question is, what are the medications which can use in CKD patients with acute left ventricular failure in primary care or resource poor settings?
Like resource poor settings, as I mentioned, heart failure patients, diuretics you can use, right? And SGL2 inhibitors, we can ask in our clinic setup, we are trying to make it available in our clinic setup. And in primary care level also, we're trying to make it available. So we can use AC inhibitors if the EGFR is more than 20%, as I mentioned earlier. Once AC inhibitors is started, if the EGFR drop more than 30% only, you need to stop the drug, refer to a nephrologist like that, and to exclude renal artery stenosis or hypovolemic. Always, once you started the SGL2 inhibitors, advise the patient to adequate hydration. Sometimes combine diuretics and SGL2 inhibitors. Sometimes there can be rising creatinine, but only EGFR drop more than 30 to 40%, we need to stop it. So SGL2 inhibitors, ANI, in the resource poor setting, diuretics, as well as angiotensin receptor blockers, and as I mentioned earlier, mineralocorticoid receptor antagonist. I think I have gone through this, right? So this is the take-home message. This is trial proven for patients with chronic kidney disease and heart failure. Preserved ejection fraction. Any other questions?
Yes. Shall we consider to start ARNI-ARB in patients with acute heart failure who is on inotrope support and with low EGFR?
Who is on inotrope support, actually we can't use antihypertensive. That's why once we started drug also, we need to monitor the patient's blood pressure. So blood pressure need to be stable. So we can't use a patient with who was on inotrope support, ANI. The patients mainly I mentioned who are hemodynamically stable, not sometimes normotensive or hypertensive patient. And once you started the drug, you need to monitor the blood pressure as well as monitor the patient's clinical status. So you can't start a patient with inotropic support, ANI. So who is on inotropic support? Actually, we can we need to offload the patient, right? If the patient's blood pressure is stable, we can initiate diuretics. And if the blood pressure is unstable, we have to offload the patient. Ideally, it's as I forgot to mention it, continuous renal replacement therapy. So if the blood pressure is unstable, if the patient is heart failure, who needs offloading, as I mentioned, we can use continuous renal replacement therapy or initiation of peritoneal dialysis. So offloading is the main important thing in a patient with heart failure and chronic kidney disease patient. So this patient, hemodiafiltration, or this is not the dialysis, mainly hemodiafiltration, gradual reduction of ultrafiltration clot if the blood pressure is stable. If the blood pressure is unstable, initiation of continuous renal replacement therapy, and we can consider IV diuretics. Offloading. Offloading is the very important thing.
The next question is, what is the place of GTN in acute nephrogenic pulmonary edema?
Yeah, that's what GTN, we nitrates for chronic kidney disease patients not indicated. Actually, it's like a symptom relief drug, not prognostic benefit. So in heart failure with preserved ejection fraction patients, they always are suggested in a chronic kidney disease better to avoid nitrates. So nitrates are not indicated.
Next
I mean,
question is at
maybe heart
time.
failure. Okay.
Sorry.
No, no, no. Continue.
Yeah, next question is at times of symptomatic pleural effusion or ascites in heart failure plus CRF patient, what is better, dialysis or albumin?
We never use albumin when the patient is heart failure and overload patient. So best, as I mentioned, offloading is the best option. So you can ideally continuous renal replacement therapy or hemodiafiltration or chronic ambulatory initiation of the peritoneal dialysis. So that is heart failure. And if the patient is not uremic, you can use IV furosemide diuretics. And even though once initiated IV diuretics, even though creatinine is rising, you should not stop the drug because it is permissive hypercreatinemia. You should not worry because creatinine rising means we are offloading the patient, right? Only if the EGFR dropped more than 50%, if the patient develops symptoms of significant uremic, like in stage, then we will consider hemodiafiltration or gradual reduction of ultrafiltration with gentle dialysis. I usually use low blood flow rate, low dialysis flow rate for heart failure patients, and ideally continuous renal replacement therapy or peritoneal dialysis. Initially, you can use diuretics. Don't stop the drug. You should not use albumin for patients with heart failure.
Then two people have asked about the contraindications for empagliflozin and SGLT2 inhibitors.
Yeah, contraindication, that's a good question. If the patient is having recurrent genital infections, we usually do not use SGL2 inhibitors. If the EGFR is lower population, like less than 20% EGFR patient, we usually do not use SGL2 inhibitors. And the patients with peripheral vascular disease, recurrent genital infections, and ketoacidosis risk patient. When we initiate the drug also, we should warn the patients about ketoacidosis. So ketoacidosis is a high risk. And lower EGFRs, recurrent infections, and the patients with acute illness. Patients who are acutely illness patients, we usually do not use that drug. SGL2 inhibitors, we usually do not initiate if the patient is acutely ill. So any more questions? I mean, like clinical examination is very, very important. And then scoring system, we can use to diagnose it. And
then there's another question about use of troponin I in MI in CKD.
Troponin I we need to do, usually troponin I can be higher in CKD population. We usually do serial troponin I values. So if the serial troponin I is rising more than 12.5, rise or drop more than 12.5, then it is significant. So we need to do serial troponin I values. So BNP, I think no one had asked questions, right? BNP levels?
Sorry?
About BNP levels, I mean, BNP levels anyway higher in chronic kidney disease patients, but if it is normal, we can or low, we can exclude heart failure in this chronic kidney disease population.
Then there are few questions we received in the pre-survey. During your lecture, you have explained most of them. There's another practical question. How to refer patients from DH to tertiary care center? Do we need to do any investigations before transfer?
Yes, that is a very good question because for to take nephrologist opinion, right? Diabetic patients with chronic kidney disease, you all can manage them in primary care center, right? But if the patient's EGFR is rapidly dropping, more than 5 ml per minute per year, like there's a rapid decline in GFR, always refer to the nephrologist. And then if the patient is having nephrotic syndrome, right? Then always refer. And if there is an indication for renal biopsies like UFR shows active sediments or resistant hypertension patients, then always refer. And if you think that once initiate the drugs, there's rapid decline in EGFR. And all the patients with EGFR less than 30%, you all need to refer. All the 30% of EGFR, you all need to refer to the nephrologist in tertiary care center. Otherwise, diabetes, hypertension, and diabetes with chronic kidney disease, you all can manage in primary care center with initiation of AC inhibitors, initiation of SGLT2 inhibitors, monitor the renal functions, monitor the UACR. But if the UACR is in nephrotic range, always refer. If the EGFR is less than 30, always refer. Once initiated the drug, if the EGFR declining, then rapidly, then always refer. Or UFR showed active sediments, always refer. Otherwise, all the patients with acute kidney injury need to refer to the tertiary care center. All the patients with AKIs, all the patients with urine or active sediments, low EGFRs or rapid decline in EGFR. Otherwise, diabetes and diabetes always managed. But hypertension with chronic kidney disease, sometimes we need to do renal biopsies. So there's those patients you need to refer to the tertiary care center.
So, our sincere thanks to Dr. Nadeesha Nishanthi, consultant nephrologist in Teaching Hospital Anuradhapura, for your excellent lecture and the precious time. So, before winding up the session, dear participants, please find the link in the chat box and give your feedback and fill the post-assessment question. Then you can receive your certificate for participation. Thank you, everyone. So, let's wind up the session for today.
I think there's one more question in the chat box. What stage we need to stop ACE inhibitors or ARBs in CKD patients? As I mentioned earlier, once initiated a drug, if the EGFR drops more than 30%, you need to stop the drug. Or hyperkalemia, like what if the potassium is more than 6, you need to stop the drug and treat for hyperkalemia, and then only you can initiate. Otherwise, all other patients, if the EGFR is more than 20%, you always treat the AC inhibitors. Is BNP available in Sri Lanka? Of course, in Anuradhapura it is available. I don't know about other centers. Someone asked about fluid management. I think I have mentioned it.
Yeah, thanks again, Dr. Nadeesha.